Hello, welcome to Quarter Past 65, a podcast dedicated to amplifying the voices and experiences of senior citizens in Nigeria. In each episode, we explore the rich histories, challenges, and triumphs of older adults. We shed light on their invaluable contributions to society. We have a very special person on our program today. She is Dr. Ogugua Osi Ogbu. Dr. Osi Ogbu is a renowned physician and geriatrician. She's head of geriatrics at the Department of Geriatrics Medicine at the National Hospital, Abuja. She's an experienced consultant physician, a geriatrician with demonstrated history of working in the hospital and the healthcare industry. She has the professional skills that are needed for clinical research, medicine, healthcare management, and public health. Professor Ogbu, or Dr. Ogbu, is a huge proponent for improving the well-being of older adults. She's a fellow of the American Geriatrics Society. You're very welcome to Quarter Past 65.
Thank you, Ma. Really good to be here with you. I love the ring of Quarter Past 65.
Yes, thank you very much. In simple terms, what is geriatric medicine? Most people are familiar with your usual OBGYN,
Right.
cardiologist, neurologist, orthopedic surgeon.
Right.
Geriatric medicine? What is it?
Right. Very important question. And in fact, when I got back to the country about 20 years ago, when I would mention that I was a geriatrician, people go, Jerry, what? What does that mean?
Gerrymandering.
Can you spell it?
Yes.
But I'm glad that today, at least often I don't have to spell anymore. People have an idea of what that is. So basically, it's the field of medicine focusing on absolutely, on the care of older people. Because we know that that group of the population have unique needs. Their health needs are very unique. They have social needs. And unlike traditional medicine, in geriatric medicine, we are concerned about all of the social determinants of health because those have great impact on the outcomes of health issues in older people. So as a geriatrician, I'm looking at the living dynamics of an older person, level of financial stability, their level of dependence on others for their care, their level of dependence on others for decision making.
Yes.
And all of that affects the outcomes and their well-being. So that in a nutshell is what geriatric medicine is about.
What made you veer into this field?
Very interesting. I did my residency in internal medicine at the University of Pittsburgh Medical Center. And Pittsburgh is said to have the second largest population of older people in the United States.
Wow.
The largest population said to be in Florida. But we think it's the same group of people. When it's winter, yes, they're in Florida. When it's summer, they come back to Pittsburgh. So as a resident on the general medicine floor, we saw a lot of older people. The population of older persons were quite high. And I found geriatric to be very novel at the time.
Multidisciplinary.
And that sort of endeared me to that. And I had fantastic, mentors and trainers in the division of geriatrics at the University of Pittsburgh.
And I dare say a wonderful relationship with the older adults.
Absolutely. So you do something really small, just showing their attention. They're super grateful. And that really I found very endearing. And I have loved every minute of it.
Although sometimes they can be quite spiteful.
Maybe not spiteful, it's us understanding.
Okay.
It is the approach. When we do not approach them with understanding, there's some pushback. So it's really family members, friends, the community, knowing how to approach older people. they're dealing with a lot of vulnerabilities.
Yes.
You can run, you can talk, you can hear, you can see everything you want to see the way you want to see it. A 75-year-old, 18-year-old might not have the luxury of that.
I'm getting there and over.
Right. So that's what I said, might not. We all don't age the same way. And that's the other thing. We tend to put every older person in the same box.
Yeah.
But aging is so heterogeneous. You see, you're fantastic at 76.
Thank you.
Amazing.
Thank you.
So you would see there are 50-year-olds who don't look as well as you do because they haven't aged as well.
And this is the right place for us to segue into what is aging. I say that aging is just a natural process of growing up,
Yes.
not growing old.
That's
growing
it,
up.
of just getting older. So nobody's old in our parlance. We just say you're older than the people who are coming behind you. Or today I'm a day older than I was yesterday. That's basically what it is. So aging is just that dynamic process that takes us through from day to day or year to year. But we know that with that process of getting older, there are changes at the cellular level that eventually affect function, both physical and cognitive.
But it doesn't mean, as some doctors would tell us,
Yes.
anything that happens to you, oh, you're old. You're old.
No.
And I get so tired of hearing that.
You're absolutely. So that is what we describe as ageism.
Ageism.
Meaning discrimination, prejudice based solely on age. Or you're 85, so you should be blind. Or you're eligible to have a hearing impairment. We don't need to do anything about it. No, that's not correct. Everyone, regardless of your age, has a right for medical access, social services. So an 80-year-old suddenly develops or is having dimming vision, we need to see what it is. So that individual should be taken to the hospital. The same about hearing. They should get access to good quality healthcare like anybody else.
Can we prepare for aging?
Are we prepared for aging as a nation? Or can we prepare?
And then as a nation especially.
Absolutely. So just like anything else, having a plan is what will most likely make you succeed at what we describe as healthy aging. So the WHO gave us this decade of healthy aging just for us to spotlight on what should be done so that as people live longer, they actually remain healthy. So one of the things we must do is across the life course. So aging, we used to say, began at birth, but now we know that there's adequate evidence that it actually begins from conception.
Oh.
So that period during gestation, when the child is in the womb of the mother, is critical. What kind of what nutrition is this woman getting? Does she have access to good antenatal care? Is she receiving all the antenatal drugs to keep her healthy so that what she's transferring to the child is adequate nutrition-wise? Is this mother a drug addict? That child is not going to come out the same as the one whose mother, was not a drug addict. Is this mother, does she have chronic conditions like hypertension, diabetes that have not been well managed?
HIV.
Does she, HIV, exactly. Does she live in an environment where there is war? Where she doesn't even know where she's going to lay her head the next night?
Not to talk of the baby that's gestating.
So all of those now, we know that. So it's important that we have healthy gestation. And we go on to the next stage of healthy development where the child is going through infancy, adolescenthood to puberty. And then we have healthy reproduction. And then the last stage of
So
the aging.
So how does the geriatrician manage all of this? In
We-
other words, you have your finger in every
So
thing about the life process.
Our role then is to keep the campaign going. That, yes, it's a life course approach. We don't start looking at you only from the age of 60. If people can live across the life course, healthy nutrition, exercise, avoiding conflict, avoiding undue stress, in the childhood period, making sure that everyone receives the necessary vaccines that they require, then you're likely to live longer without disability. And if you're healthy at an older age, you continue to contribute, just like you are doing. There are people at 76 who cannot contribute because they're either bed-bound, wheelchair-bound, so they can't get out. But we even say, despite such challenges, such individuals should be given the support to continue to contribute if they so desire.
Health is a big challenge for anybody who's 65 and over.
Yeah.
What are some of the basic health changes or challenges that these people in this particular age bracket face?
Tend to face. So you mentioned earlier that aging is just physiological.
Yes.
And that's what it is. So while age in of itself is not a disease, unlike what some doctors and people out there think or practice, it is a big risk factor for chronic disease conditions like high blood pressure, because of the changes in the blood vessels becoming harder, thickened. Increases that risk for developing high blood pressure. The same as an increased risk of developing diabetes mellitus, which is changes in the sugar content in the blood. And we know that diabetes also increases the risk for other things like stroke, heart failure, heart attack, the risk of you having your limbs being amputated, because diabetes is a multi-systemic condition that affects blood vessels. And we have blood vessels everywhere, the eyes. So people get blind from poorly controlled diabetes. In the brain, so the stroke, the blood vessels go into your heart. They give you the risk of the heart attack. So it's a disease. I always describe it as, when people have it, you need to face it like a general war.
That is
diabetes.
Diabetes. Wow.
Because of its multi-systemic effect. So how do we determine whether you have diabetes or not? Even before you develop it, there are lifestyle practices that increase the risk for developing diabetes. So if you're sedentary and not moving, if you're overweight, obese, you have obesity, if you have a family history of people, in your family who've had diabetes, that increases your risk for developing diabetes, in addition to the aging. So we're seeing, when we find, we have two types of diabetes. We have the type 1, which has to do with insulin deficiency. So the pancreas, where the insulin is produced, in such, when you say babies who have some genetic problems within the pancreas, develop into a mature state to produce insulin. So you will see the type 1 type of diabetes in such babies. Well, for the adult type of diabetes, which is the type 2, is a more common type of diabetes that we see globally. It has really mostly to do with lifestyle. So if, again, you can live a healthy lifestyle from a really young age, you should be able to prevent the development of diabetes even in your older age. So making exercise a way of life from the get-go, eating right consistently, making sure that your weight, or your, what we say, body mass index, is optimal, so that you do not develop obesity. Ensuring that you avoid smoking, you avoid excessive alcohol, because all this increase or accelerate the complications that can develop from diabetes as people get older. So yes, hypertension, diabetes. The other very common thing is, as we age, our joints are undergoing degeneration. So degenerative joint disease is another common condition that we see with aging. What we'll typically say arthritis, and it can affect any joint at all, the big joints, small joints. So the big joints typically are more affected. Your knees, your hips, shoulders, and then the joints of the spine.
Tell us about it.
So again, it's wear and tear. We're using the joints as, you bend over, you sit up. So our joints really undergo that wear and tear. And there are, again, certain lifestyle practices that make that worse. If you're overweight, or obese, it means your knees are carrying a lot more than they need to. If your vocation, if you're a driver, long distance driver, it also increases the risk, because you're sitting for a prolonged period of time, of developing the arthritis in the lumbar spine. The entire spine, even the neck, even the cervical spine. So just understanding all of this. It means...
How do we begin to understand all of that? Especially in a place like Nigeria, we've not even finished dealing with some basic economic and social issues.
You are absolutely right. I had a focus group conversation with some older people in a rural area. And then I said, what would you like the government to do for you? And in fact, this particular woman just laughed. She chuckled. This was about 8 years ago. And he says, government do for me? There's no light. There's no water. And it was, for me, heartbreaking, because I wanted them to focus on specific issues relating to aging. But here we are, just what you have said now. We haven't overcome basic provisions. So they can't even think that far as to, specific for me, for my age group. Because here are basic things that are confronting me. So we just have to keep the campaign going. We must introduce the issues of aging in schools. So, and we can create aging clubs in schools. And maybe this is something Quarter Past 65.
Sensitization,
awareness. Exactly. I'll tell you something. A friend of mine was talking to her grandchild, and he said, how old is, her grandchild. I wanted to know, so how old is great grandpa? Meaning my friend's father. And said, he's 82 or something. So he will soon die. And this is a 3-year-old. So that's his thinking. That, once you're at that age, the next thing
is that you will die.
Right. And that's somewhat ageist.
They're not linked, though.
No, they're not.
Age is not linked to death.
No. There are 40-year-olds who are dying from different things. There are 20-year-olds, So again, that education. So in fact, I said to my friend, we need to come to his school and talk about this. That are 80-year-olds that are doing great things all over the world. 90-year-olds that are doing. So age is not synonymous exactly. So the education, we have to keep talking. The older people are empowered to seek their place. Because we've come to a place where, in our country, where older people, again, we describe this as self-ageism. I've seen some of my clients who will go, doctor, don't waste so much money on me. My children will need the money to look after my grandchildren, something like that. So we must get to a place where older persons are not so dependent They have health care that is provided for, that is not tied to their children providing the funds. So health insurance, social services that is not tied to family members.
You're moving very fast. You're still watching 65. Stay with us, but we'll be right back. Welcome back to 65. And in this very special episode, we're talking to Dr. Ogugua Osi Ogbu, the only geriatrician in the whole of Abuja, the FCT. And she's been here working with the communities, with various stakeholders in those 20 years, trying to educate, sensitize, and also to deal with particular health issues of the elderly. You're welcome back.
Thank you very much.
Now, how do most older people, I need to get the terminology right. I say elderly, I say older citizens, I say senior citizens. What's the right terminology?
So globally, it's what tends to be used or allowed is the older person or the older adult. And you can use, senior citizens, but not elderly. The elderly is said to promote
so used to it.
Some negativity.
Yes, but you even find that my eldest sister, my elder sister, and I'm saying, oh my God, I'm not your eldest sister.
Yes. So yes, but I find that here, the Nigerian older adult population did not necessarily mind it, but globally, really, most when we're communicating about older persons or older adults or seniors, that's okay.
Are health systems equipped to deal with the myriad of challenges that older persons face?
Let me go back to some. I did mention hypertension, diabetes, and the degenerative joint disease or the arthritis. But there are a group of conditions that we describe as geriatric giants, and that's because they affect function and quality of life significantly. One of them is the cognitive impairment, dementia.
I was going to ask dementia.
Right. I'm just going to mention, dementia. The other geriatric giant is falls and mobility issues. So when people have severe arthritis, it can get to the point where they're disabled. They develop deformities of especially the knees, and they can't move anymore. So they're not moving, they get bigger, it just becomes a vicious cycle. And it increases their risk for falls. And falls is a major geriatric syndrome. We don't like to see falls because
why not?
When older people fall, so many different things. You can give us a cascade of things that happen. So this person falls, might have a fracture. If you have a fracture, then you're in the hospital. We might need to do some intervention for the fracture. Complications might set in because you're in hospital. Prolonged hospital
other people
stay.
Have fractures.
Other people have fractures because with the older bone that has become thinner than that of the young. It's a lot more fragile. Options for intervening on the fracture might not even be that. Might not be
that easy.
More
complicated.
Because if it's a very fragile bone, even going in there with a pin and plate, you might be fracturing other parts. So you have to do what we call conservative management, and that requires a prolonged hospital stay. If you're not even in the hospital, it means somebody needs to support you because now you can't bear weight on the fractured bone. You need a whole support system to help that older adult overcome that incident of the fracture. There's also the issue of the psychological setback. Oh, why did I do that? Why did I allow this to happen? Now my children have to be around to support me. Do
Kind
my
of a
cooking.
guilt syndrome.
Yes. And the anxiety that comes with that, even depression. And some have been known to even stop walking after a fall because of that morbid fear of having another fall.
Almost like people who have their first accidents and refuse
To
to drive.
Yep, exactly. So they just say, you know what, let me just sit here and I won't fall. And because when they also think of the pain, the excruciating pain from the fracture, the excruciating pain post-operatively when they have any intervention for the fracture.
And the time that it took.
And the time. And again, the dependents there, family members who have to leave everything and come and be there.
Let me ask you a question. You've talked about the psychological impact. Why do old people think about older people? Why do older people think about the impact of whatever happens to them on their children? Why can't they just live? They've taken care of these children. So if you need to be taken care of, why don't you just allow them to take care of you?
Well, so I think older people are so conscious of their vulnerabilities and would wish that they were not that vulnerable. That I can get up, go get my cup of tea. I can, that would be the desire of, it's human nature. You don't want to be dependent. You don't want to be the one that stops another individual from going on with their own life.
But you can do that. I mean, even
so
in that
as a parent,
places,
it was a natural space to be to the caregiving role. It comes naturally to you. You're super excited and grateful and feel blessed that you have children to look after. So but now parents don't feel their children should get into that space of a huge sense of duty in that way.
You say you have to go on with your life. I've lived
because
my life.
we desire for them to actually chart their own course and be able to. I mean, it will be nice that they can look back and say, oh, mom and dad did this for me. But that's why we need a system that does not require the children to be the older person to be that dependent on their children.
Just before we leave that area, do you find that women do this more by virtue of the fact of who women are, being caregivers, being caretakers, this and that, nurturers? Do they feel more that they don't want to be dependent than men do? I don't know. Do you find that in your practice?
So when we have not really looked at the evidence of it, but we find that when the men are the ones who need care, everybody's there to provide it.
Yes.
The wife is there, the sons are there, the daughters are there. But you might find a woman who's needing care and it's probably just a caregiver and maybe a daughter. And her husband might never even show up.
He's going about his business.
He's going about his business because I guess he's just naturally never gone into that mode of caregiving, which again is a reason for us to teach our boys caregiving role.
Yes.
Let them know that those roles in the home, domestic roles, even in the kitchen and all of that, is everybody's business.
And I'll tell you something. My brother was saying something about his children. He said, "Oh, I don't want to mention the name, that she's always here."
Right.
Said, "But they all and then he now made excuses for him.
Right.
He's raising his own family." And I wanted to
Is she not raising a family yet?
Well, she's not yet.
Okay.
But you would find out that even if she were raising a family, she would still
looking back.
be there looking back.
Right.
Yes. The federal government has put in place the National Policy on Aging, which came into being in 2021, and there's a blueprint, and there's this multi-sectoral, multidisciplinary to deal with the approach to deal with the challenges of aging and cater for the needs, health, social systems, and what's that thing that they always they care, the social safety net system. In your experience since that aging policy came into being, how would you say that it has cascaded down into what we see today in the healthcare industry?
That was a major hurdle to cross, because that aging policy was in draft form for many years, but thankfully it was finalized and launched, and has been a blueprint that the agency of government that was created, the NSCC, the National Senior Citizen Center, has now used to roll out programs. So the first thing the NSCC DG did was have a strategic plan.
Yes.
And to develop that strategic plan, she did a very important thing, getting all the experts, the stakeholders together, again, the multidisciplinary groups, to come up with, for health, what are the things, social services and all of that. So that strategic plan is what the NSCC has used subsequently to raise awareness, collaborate with other MDAs. So prior to the NSCC being established, there were MDAs that had mandates for older adult care, but didn't even look into those mandates at all. They were focusing on other things. But NSCC, with the collaboration, brought it to the fore and say, look, hey, your water and sanitation, what are you doing in the communities for our older adults? Your transportation, what are you doing to make sure that older people can have seamless experience when they have to get on our buses and all of that? Housing, what are we doing to make sure that even older people who have to use walking frames or even in a wheelchair can have access?
Even in the banks.
And banks also being able to prioritize our older persons. And that's part of us being able to create. So the NSCC has tried to ensure that we are creating or attempting on the journey to creating a healthy and age-friendly environment, making our nation and our communities age-friendly. So through the collaboration...
How deep do you think that has gone?
I know that the DG did a lot of all that collaborative work. And the other smart thing that she did was creating state chapters of consultative groups, stakeholders in aging in each state, who were now like the foot soldiers, to say, hey, are you guys aware in this state that there is such a policy at the federal level? And some of those consultative groups have been able to engage their state, the leadership of their states, to actually domesticate the NSCC Act. We know that the NSCC was actually established as an act of parliament. But the federal government doesn't own the citizens. It's the states. So yes, the federal government, gives a direction as, this is what we think will be appropriate. But at the state level, the leadership need to own. So first, there should be a state senior citizen act,
And then it
and
has
that
to go down.
yeah, and then it has to go down. So that must happen for that impact to actually be felt at the and the grassroots is where we have about 70% of our older people. So this needs to go down to the communities. So what Quarter Past 65 could be doing is making sure that the leadership of states are aware of the fact that they need to domesticate this act and be able to carry out programs for their older persons.
And bring the older persons out to talk about it.
Yes, exactly. Because I remember the first engagement of the NSCC with older persons, the older persons came up with a slogan, "Nothing for us without us." So you have to engage them. You have to bring them to the table. And they state, their needs for you to roll out the programs.
Because indeed, you can't just set up something for people, and what if it's not what they like? Because that's a basic
it's like constituency programs that go to communities, and the communities had not been engaged to say, okay, so you give them a massive hospital that is, 10 kilometers away from where majority are. It's going to remain there and not be utilized. But if they tell you, our first set of needs are this, we need water, we need this.
Can you be very specific about the gaps that you have found in the healthcare system? What are the gaps?
Right. So
how do we begin to?
The major one is even the lack of geriatrics in the curricula of doctors. I mean, for the medical doctors, medical students is beginning to change because now we have that. But all the other allied health, nursing, pharmacy, physiotherapy, because these are all the different disciplines that we work with in caring for older people. Medical social work. So we need geriatrics.
We don't do vaccinations, do we?
For older people. It's not in the national program of immunization yet, but there are vaccines available. So that's one of the things we're also trying to push for, the level of the Geriatric Association of Nigeria to let the government see, certain needs. So the health insurance. And there's been talk about health insurance that is affordable to older people, but the modalities of it, the NHIA is still working on. So that hasn't been rolled out yet.
You're talking about affordability. Yeah. What about the kind of health insurance that does not include the older person?
So I find that even the basic NHIS that we had, you could still push to get more. I've had clients who had, cancer diagnosis, and the health insurance will only cover so much, but they come to us, ask us for what the estimate cost will be, and they write to the NHI at the time to say, look, this is what the hospital is saying, and sometimes they actually do get a little more than the basic coverage. So the conversations are still ongoing. I know that the leadership of the NHIA put together a team to look at how to roll. Because the reform now is mandating every Nigerian to have health insurance. But the committee is still working on the modalities of that. So that's one, that people who will be looking after older people should have the requisite training.
Yes.
So that curricula need to change to include geriatrics. The second is, even when the healthcare workforce are trained, the environment, making the healthcare facilities age-friendly. Talked about, you should have a ramp to allow those who might be using devices or aids to walk. There should be adequate signage so that they know where to go. They can, navigate the healthcare facility. Be it at the primary healthcare level, all across the tiers. Adequate lighting, because we know that for older people, the changes in their eyes require that there's a lot more light for them to appreciate figures, colors, and all of that. And the attitude of the healthcare workforce.
Yes.
And that starts from the man at the gate. As this older person is coming, whether, she walk in, he being friendly. Oh, can I help you? Where are you trying to get to? And not looking at you as, Mama, what do they do here?
You not go stay for house. All this mama them. All this papa them.
The attitude is so important across. So it's not just the doctors and the nurses, but everybody that senior citizen will have to encounter.
And then I dare say, going back to the thing that you said earlier on, in the schools, how the young ones view older people.
Yes. So that's why those aging clubs will be really useful in the schools. And in fact, if our children know, they can then practice what they, what they're learning in school. They now pay more attention to grandma. When grandma is coming to visit, they're not, grandma is going to insist I go to church. I don't want to go to church.
Or grandma is going to dress.
Come on,
and talk properly.
Yes.
And don't bring the phone to the table.
Yeah. So they will be more appreciated because, we all pray to get older, but we must put that prayer into action by also treating those who are older than us today with respect. And as we do it, those who are younger are watching.
Yes.
So that they can also treat you the same way. But if you haven't done to the older ones, don't expect to get it from the younger ones because they didn't see you do it. So it's really important that.
We're still here. This is 65:15. We're talking to Dr. Osi Ogbu about aging, taking care of the older persons. We'll be right back. Welcome to 65:15. It's been such a wonderful conversation with you. I'm going to do my very last as we get to the end of the program. Two things that are related concerning health, concerning care. You talked about it, dementia, cognitive impairment, Alzheimer's. We're not going to go into the nitty-gritty
details, yes.
But most of the time, apart from the lack of mobility, those are the things that may lead to nursing homes. What's your take on nursing home care? Or should it be an absolute no-no, a cultural taboo?
Okay. So we always say that older people need care in different settings. Acute care setting when they have an acute thing, maybe a pneumonia, an infection in the urine. They come to the hospital, we treat them for a few days, and they go home. There are those who come with a fractured case, for instance, or a stroke. Coming with a stroke, you're in the acute care setting, but we don't need you to remain in the acute care setting to rehabilitate. So you need to go into a rehabilitative care setting. So we need a rehab setting. And sometimes that rehabilitation can be provided within the confines of a nursing home. So what a nursing home would do, let me use the word long-term care would do, which teaching you how to get back on your feet again. You might have pressure ulcers that all we really need is just dressing for that wound. So you don't really need to be in a big hospital for that. So you're in the nursing home or a long-term care facility for wound care, physical therapy, occupational therapy, just again to try and get you back to your pre-illness state.
Do we have those?
We have a few scattered across the country.
The rehabilitation and convalescence.
Right. So, Ibadan is a great place to be an older person now, because they have a geriatric center, multi-purpose, specifically built, one-stop shop for looking after older people. So their dental clinics are run there.
Wow.
Eye clinics are run there. ENT clinics. So they don't have to go like. If a client comes to me at the National Hospital and I say, go and see the eye doctor, they have to move from my clinic to a different part of the hospital. Go and see the ENT, they have to move. So there's a lot of movement. But for an Ibadan older person, it's right there within the center.
Is there
and next to them
being replicated?
That would be ideal, that we have that in every geopolitical zone. The one at Ibadan was actually built or donated by a philanthropist, the late Anini, God bless him. So if we can find similar philanthropists to replicate across the geopolitical, we definitely need one in Abuja, being the federal capital territory. Next to that geriatric center, it's also a rehabilitation center, specifically for seniors, for older people. So everyone there is trained to look after older adult issues. So when they come with their fractures and things like that, or post-stroke, that's where they can be to rehabilitate. Now there are those with cognitive impairment. Dementia, Alzheimer's is the commonest type of dementia. Or we have 3 other forms: vascular dementia, dementia with Lewy body, and frontotemporal lobe dementia. So all the different types. But either way, it gets to a point where that individual is so dependent on other people for their activities of daily living, even bathing, feeding, moving. They need somebody else to help them with it.
And the relatives cannot do that?
The relatives can do that, but here is the thing. The relatives, for them to do that, they also have to be trained. So in fact, the NSCC, a group of us came up with the basic curriculum for caregiver training. So caregiver can be someone that you're going to pay, or a family member that should have basic skills. How do you approach this person? How do you help them with medication management? How do you support them so they don't have falls? All of those geriatric giants that I talked about. So it's important that whoever is going to look after them have the prerequisite basic knowledge and skills. So we can leave them at home. That would be preferred, that you have what we call hospital within the home. But whoever is going to look after them must have some basic skills and knowledge. But I have come across family members who cannot deal with the psychological impact. I had a lady who said, I need my mother to go somewhere else, because every time I'm coming home, and I realize I'm coming home to a mother who no more recognizes me as her daughter. So she doesn't have the bandwidth to deal with that. And I cannot fault her.
Can training help?
So understanding might help. Understanding that, okay, this is what's going on with my mother. It's not her fault. It's not my fault. But I'm still going to love her and continue to care for her.
But I don't have the capacity to deal with that on a daily basis.
So she was looking for a place where, even if it's during the week, I bring her home during the weekend, just something to give her some respite. And we should have a system. We should give that option to family members. Because some start feeling guilty just because of the way the society looks at. Oh, she sent her mother off to an old people's home. And we don't like to use that. We say there are residential facilities for seniors or residential facilities for older persons. So it's okay if you are not the one with the bandwidth, to deal with that. And it might only be maybe for the first 3 months or 6 months. And once the person comes to an acceptance of, okay, so this is what has happened to my mother now. All right, well, I'm going to have to deal with it. You can then bring her back home and do all the loving and all that. I have a friend who, she doesn't even get any help in to look after her mother. She's on bathing, and she says she's just loving it. What has helped her with that is the fact that she hasn't had to do any formal work. So her husband, and the kids are all grown, they've left the house, so she can spend all of that time, because she also realizes, well, she's not going to be here with me forever. So
it'll come to a time when she
just wants to pamper her for this time until, God calls her home. So we have to be a system or a community or a nation that gives room for the different sets of family members and their needs for their older persons.
And the different degrees of the health challenges.
Yes,
that
exactly.
people may not be able to deal with at home.
We should have those residential facilities available for family members who say, you know what, I really need my mom, I need my dad to be somewhere for now until I can come around. And there are times when, the people with dementia, they have episodes of confusion where the family members are just at a loss as to what to do. How do I handle this? And some are so, what's the word I'm looking for? I don't want to use the word scandalized, but they just feel so distressed by it that it's not something they would like to witness. Your mother is walking around stark naked in the house, and you're wondering, I don't want to have to keep dealing with this. So again, this is why we need healthcare workforce that would understand this. Because, we're also in an environment that is so religious. Some will put it to, it's an attack. And will not bring that woman or the man
to the hospital.
Just leave her there, just bring holy water and all that. But really, everybody should get access to good quality healthcare. That means we must adequately train the healthcare workforce to recognize these issues in older people, and also be able to counsel family members, also be able to recognize caregiver burden in family members. So when I'm at my patient's bedside, I'm not just looking at the patient, I'm also looking at, okay, there's 2-3 people around her, they really look like they need to get some rest.
Exactly.
So caregiver burden is another big issue, and you can only give care if you are in a good place yourself, physically and mentally. So we recognize that. We even have a tool to assess for caregiver burden in geriatric practice. We have tools that we use a lot, in assessing our older people, finding out about dementia, anxiety, depression, and all of that.
And the bonnet syndrome.
What do you mean by bonnet
They
syndrome?
say there's a bonnet syndrome. A bonnet syndrome where the
bonnet
person,
like the hat.
Bonnet like the hat, where the person does not really have dementia, but manifests most of the symptoms, of dementia, where they're seeing people almost like schizophrenia or something like that.
So
that's what
there is forgetfulness that the physiological brain changes, will bring about. that is not dementia, just forgetfulness of aging. No more forgetfulness of aging. There is also the mild, what we call the mild cognitive impairment, which is a very early stage of what you might call the dementia spectrum. So they have the forgetfulness that does not impair function. But for those who have developed dementia, it actually impairs function. So dementia is not the only mental health issue that we see in older people. They also have things like schizophrenia. They have what we call late stage schizoaffective disorders. So we tend to manage such people in collaboration with the psychiatrist, right? So with dementia, they are at increased risk of the state of confusion I mentioned earlier, which we describe as delirium. And with delirium, they can have hallucination.
Yes.
They might be seeing things, hearing things. So when we see an older person for the first time and they're manifesting signs of delirium, once we get over that, we do a deeper evaluation, a more comprehensive evaluation to look for any underlying dementia that might not have come to the fore prior to that episode of delirium. So I don't know if that's what you're describing as the bonnet syndrome, the delirium. But let me go back again, because it's important that people understand this geriatric giant. I mentioned the falls and mobility issues. I mentioned dementia, but there's also the impairments in hearing and vision, and then incontinence, which is a big thing. So some people say, oh, there's a normal way older people should smell. But that smell only comes because of the personal hygiene. So if this older person cannot move as quickly as you could, can no more wash her clothes or his clothes,
cannot move fast to get to the bathroom.
Cannot move fast to get to the bathroom, exactly. And then they have accidents with urine. Their clothes are always having small stains, and if it's not changed and washed, you would get that smell around them. So that's one of the giants that we tend to ask about, because sometimes people are shy. So we'll say, oh, we know you're not moving as quickly, and so you might have, you might have to rush, and you're not able to quickly get there, and then the urine starts. You're like, oh yes, and then you find out how often this is happening. So there are ways to cope with that. Don't wait until the urge has come. We always say within 2 to 3 hours, just get up, take your time, stroll there, do your business, come back again. And that allows the opportunity to also exercise, because we're all supposed to take 7,000 to 10,000 steps a day, and it won't happen if you're consistently sitting. And age is not a reason to not exercise. There are huge benefits for exercise. And just walking, we're not saying go to the gym, or just making sure you're constantly moving. Even at 90, even at 100.
Even at 100. I saw a video today of a man that's 200 years.
Well, 200?
200
really?
Years in India. The man is...
because the record, is the record holder for the longest living person. It's supposed to be 126, but I guess
that's too young. We have plenty of them in Nigeria.
Beyond that.
We have many 120s, 170. But this guy is 200 years old.
Wow.
And he can still move. But of course, he's gone till, but he can still move. It is just incredible.
And I guess maybe it's a culture of always wanting to help. So we make the older person say, mommy, let me help you. Oh, daddy, let me help you.
And then when you say no, then they stop helping. And then when you really do need the help, they say, oh, no, she doesn't want your help.
No, well, this is what I say. Do as much as you can for yourself. Get up and go and get your bottle of water. Get up and go and get your cup of tea. Take your plate from the dining table back to the kitchen.
Even if you won't wash if you can.
Exactly. So we want people to keep doing things. Don't don't contribute to accelerated aging just because everyone around you is saying, mommy, no, don't worry. Oh, daddy, I'll do it for you. No, say no, I want to move. The doctor says that I should move. I need to keep moving. Let's support them, but don't make them become like a piece of furniture in the home. And,
a castaway or something.
You know, they need to.
Well, it's been absolutely riveting conversation with you. And I know that we've just glossed over, but that's enough to maybe sensitize people and tell them what to do.
Right.
We'll definitely bring you back to go into more detail about dementia, Alzheimer's, and all that health.
Congrats again.
Thank you.
On your
Thank you.
first anniversary.
Thank you for joining us today on 65. We've had a wonderful conversation with Dr. Osi Ogbu, a geriatrician in Abuja. Oh, when are you planning to make sure that there's not just one of you?
Oh, so yes. I forgot to mention that as part of the progress that we have made. We now, National Hospital Department of Medicine Internal Medicine is an accredited training center to train doctors to become specialists in geriatrics. So currently I have 3 trainees.
Wow. Awesome.
Yes, and we've actually trained our first Nigerian geriatrician. We got him in 2022. So yes, we're making some progress. There was no curriculum to train until myself and Professor Belgam co-authored the curriculum that we're now using to train in the West African sub-region. And it's something that's fulfilling because, some of my colleagues said, after I trained in the US, why are you returning to Nigeria? But it's been quite fulfilling.
The perennial question.
It's been very fulfilling.
We'll definitely have you come back and talk to us.
Yes, I would love to.
Thank you very much again for joining us on 65 today. We've had a wonderful, wonderful conversation with Dr. Osi Ogbu. Please remember to share, like, follow us on our social media handles, YouTube, Facebook, and Instagram. Tell us what you like or don't like about our programs and give us ideas of what other topics we can deal with. Until I come your way again, it's bye for now.